Hi, this is Brian Kim. I'm going to share with you this case of a patient who was referred for a traumatic avulsed LASIK flap. Essentially, this patient had some type of medical emergency, lost consciousness, ended up really with a black eye, facial trauma, and then had an avulsed LASIK flap on this side. And so the patient was referred. There was significant epithelial ingrowth. And so you're going to see me trying to reposition this flap, removing all of that ingrowth, assessing the tissue, the corneal tissue, and then how I'm able to suture this flap back down in this traumatic situation. So as you can see, I put some ink marks on the cornea, and what I did was at the slit lamp, I identified the area that was wrinkled and distorted, and I delineated and marked out the edge of the flap as well as the area of ingrowth. You can see based upon the ink marks that the flap is significantly decentered. So at the time when I examined the patient, I didn't know if this was a decentered cut of the LASIK flap or something else. And so you're going to see as I proceed with this case what actually was happening in this situation. So I use a Sinskey hook to score the edge of the flap here, and I'm able to use the ink marks as a guide because, as you know, at the slit lamp, it's much easier to see the flap in 3 dimensions, but when you're using an operating microscope, it's not as obvious where that flap is. So having the ink marks ahead of time that I placed while at the slit lamp is really very helpful and, in my opinion, necessary when you're dealing with these situations. So I'm going around peeling and separating the flap edge. And obviously there's epithelium that's grown over it. And so you have to use a little bit of effort to use the Sinskey hook to get to the edge of the flap and separate it. So you can see I'm just going around using my left and my right hand, just carefully trying to tease that flap off, just creating some epithelial separation on the edge. Right here, I'm showing my staff the epithelial ingrowth right here. You can see those little white dots. So I'm going to lift the edge of the flap, and you can see all of this gelatinous material under the flap, using the dry wax cell sponge to tease that material off. Plus you can feel with the Sinskey hook this gelatinous material on the stromal bed as well. I think all of it is that epithelial ingrowth. So again, using that dry wax cell sponge, peeling the flap, but also using the Sinskey hook as well to just scrape off that gelatinous material off the bed. And it's nice to have a dry wax cell and a dry flap so you can have a much easier time in peeling that stuff off. You can already tell that the flap is thin. And so in the area of epithelial ingrowth, there's clearly some necrosis and melt of the peripheral flap. Again, I'm scraping this gelatinous material that's in the interface. And I'm just going around. Again, the area that I marked out is the problem area. So I'm making sure that I lift all of that part of the flap up. Again, when this patient saw the referring surgeon, and I believe that the flap was essentially come off, they just placed a contact lens on the eye and then sent the patient over. So again, it's been several weeks that this patient was like this. Again, she had a trauma and had to deal with other issues, and because of those other more pressing medical issues, the eye was kind of left to be dealt with later. So again, scraping that gelatinous material off the stromal bed. Scraping the flap as well. You might be wondering, why aren't I removing the entire flap and lifting the entire flap? Well, there's no reason to, because the problem areas are really closer towards the edge. And if I lift the rest of the flap up, that can cause more potential complications. I don't know the status of the hinge. I don't want to have an avulsion of the entire flap. So I'm really dealing with just the problem area first. And then with a wet Wexel sponge, I massage the flap back down. And what's interesting, as I lay it back down, you can see that the flap is not a decentered cut. It was decentered because of the avulsion. So now that I've placed the flap back down, it's actually pretty well centered. So this is a tenonylon suture, placing it through the flap opposite the hinge. And this is important. The flap is necrotic, like I said. It's very, very thin peripherally. So you have to do two things. Number one, you need to get a nice bite, but you have to be very careful because you don't want to tighten it too much because it'll cheese wire through because the flap is so thin. And also, when you're suturing the flap and you puncture through the flap, you don't want to actually take a bite of the underlying stromal bed, because if you do that, then you're not going to actually get any good tension. So you have to suture the flap first, and then, of course, the stromal side on the other side, so that you can get that flap on stretch. So again, very important that you puncture the flap without catching the underlying stromal tissue, and then passing the suture through the stromal side, just like if you're doing it like a corneal transplant, like a PKP suture. But the flap part is really the key. You want to just suture the flap, but again, not underneath it, so you'll be able to pull it. But not too tight, because if you do it too tight, it'll cheese wire. So the first suture was an interrupted suture. And then you're going to see here, I'm going to run this. So I cut just the one end, and I'm going to run this, going across. Again, lifting, I lift the flap so I don't catch the underlying tissue. Lift it just a little bit, and then pass it through the peripheral cornea. So I'm going to run this, go across, and the running suture just provides kind of equal tension across the flap all around. And remember, when you have these LASIK flaps that are necrotic and very thin, you can't bury the knot. So unlike a PKP where you bury the knot, I'm not going to bury these knots. I'm going to leave the knots up and exposed, and I'm going to place a bandage contact lens on the eye. And that does two things. If I tried to bury the knot, it would cheese wire through the flap, and then of course I'd lose the tension, which is the whole point of doing this. You need to have tension so you don't have any more epithelial ingrowth. The suturing helps compress the edge, so it reduces the risk for ingrowth. It also reduces the risk for stria. So you don't want to turn the knot, so you're going to leave the knot exposed, because you don't want to cheese wire through the flap, which would defeat the purpose. And then you have the knot exposed so that you can more easily remove the suture at the very end. When you're done with the sutures and you cut it, you can imagine if it's buried and you try to yank on it, you might avulse the flap edge again. So having the knot exposed is actually beneficial for two reasons. Of course, when you do that, you have to have a bandage lens. because if you don't have a bandage lens, the patient will feel those knots. So you can see I'm just pulling, creating more tension, and then tightening it down. And it's okay to have really tight sutures here. Again, not super tight that you cheese wire, but you don't mind having them tight sutures because you're going to eventually cut them anyways and it'll relax. And then I'm going to do the same thing on the other side, puncturing through the flap and then puncturing through the peripheral cornea outside of the flap area. Tying it down and then running it the same exact way. Nice and tight, cinch it down. Cut the one edge, but then run the rest of it. So I'll backhand these, again, lifting the edge of the flap, puncturing only through the flap, and then the peripheral edge of the cornea. Again, through the flap, really, really thin. The flap is so thin. And then through the peripheral cornea. Making sure it's nice and tight. Tightening the running suture. I believe this is the last bite. And then tie it off. So pretty tedious. Obviously, there's a lot of suturing. It's like watching a corneal transplant video, just a lot of suturing. Somewhat boring. But I wanted to show the entire suturing part so you had an idea of just how light-handed you have to be when you're passing the needle through the flap. Again, it's so thin. And enough tension that you get some, again, a tight closure, but not so tight that it'll cheese wire through. So cut that one off. Again, nice closure. This helps minimize re-epithelial ingrowth by compressing the wound edge, as well as reduce the risk for stria. And that is the end of the case. And so I'll go ahead and place a bandage contact lens. This patient did quite well, and I've been following the patient for a couple of months now. No epithelial ingrowth, no stria, and the patient did well. So I hope this was helpful to you, and I thank you for your attention.